Good morning, everybody. Thank you for being here. So I'm just going to go over a few housekeeping items here really quickly. Hope everybody's really been enjoying the conference thus far. Want to make sure that everybody's had the opportunity to download our app, the NKF Meetings mobile app. This is where you can complete all of your pre-tests and post-tests and evaluations in real time, knock those out. If you need any tech help with the app, please just let me know. And we love posting on socials and uplifting NKF, so please share your experiences on social media with the hashtag NKFClinicals. And NKF can continue doing the impactful work and putting on conferences like this with the support and engagement of professionals like us. So you can receive a huge discount to join us again in Orlando at the 2027 Spring Clinical Meetings and more as an NKF professional member. And we have a desk downstairs where you can learn more. And you can also check out, visit kidney.org/membership to join today. So, we were learning that the system doesn't really play nice with Canva, so we were trying to do a little workaround here. But I'm Jenny English, and I'll be facilitating this session today, and I'm a kidney and bladder transplant social worker at UCLA. And I have the honor here of introducing our presenters. Emily Patrick is a licensed clinical social worker with 3 years of experience as a kidney and liver transplant social worker at Penn Medicine. She is deeply committed to helping patients navigate psychosocial challenges that may impact their transplant journey, while also working to enhance program policies and processes to improve patient care systemically. In addition, Emily serves as the uterus transplant social worker at Penn Medicine, supporting patients through this groundbreaking and complex medical journey. And Emily earned her Master of Social Work degree from Temple University. And Christina Serra is also on the team at Penn Medicine. She's an abdominal transplant social worker, has been a kidney transplant social worker, liver transplant, uterus transplant as well, and has made a lot of wonderful contributions to her program. So without further ado,
Good morning, everybody. Thank you so much for being here today to talk to us about marijuana. This is a really interesting topic, not just in transplant, but in this country in general. So we're really, really happy that you all came to hang out with us. So before we get started, let me just let you know we have no financial relationships. Today what we're going to do is we're going to go through a presentation talking about cannabis and transplant, but we want to give you a little bit of context first of how we got here today. So a few years ago, about 2 years ago at this point, Christina and I and some of our fellow social workers started to realize that patients who were pre-transplant getting assessed for their candidacy were being told various things when it came to their cannabis use. Some were being told, stop using altogether. Some were being told, you must have a medical marijuana card. Others were being told, we're not actually gonna talk about it. Let's just not go there. Well, our policy changed where every patient was now being drug screened upon evaluation. And people kept coming back positive for cannabis. So now we couldn't really ignore the fact that there was no specific protocol for how we handle cannabis use in transplant. So this led us to bring the topic to a pre-transplant work group that involved nephrology, nurse coordinators, and social work, and then also our psychiatry team. Through this work group, we all collaborated to talk about what are we going to do about marijuana use in transplant. Well, today we're going to talk about what we learned through this work group, what our role was in this work group, And we're going to do it while we're also telling the story of a patient, a vignette of a patient who is going from dialysis through transplant. We actually had been collaborating for the last few months with another social worker, a dialysis social worker out of Texas. She unfortunately could not be here today, so we pulled in dialysis as part of the journey, because when we meet a patient at transplant, they have a whole other medical journey with dialysis, where marijuana can play a significant role. So, all that to say, our objectives today are talking about the legal history of cannabis and how we are where we are today in the healthcare system when it comes to cannabis use. We're also going to critically analyze the inconsistencies of cannabis use policies in transplant, and then we're going to apply an interprofessional approach, talk about the multidisciplinary team and what we did together. And then we're going to just discuss some of the strategies that Penn Medicine, or the University of Pennsylvania, has now implemented with our patients who are seeking transplant and are using cannabis. All right, so we're going to take you on a journey with Elena. Elena is a patient, and we're going to start her journey off at dialysis. These next few slides were Kristen's slides. Christina volunteered to cover her slides, so I greatly appreciate Christina for doing so. So she's gonna start us off where Elena is at dialysis.
Okay, so Elena is not a real patient, but she's based on experiences that we've had, whether that be Kristen's experiences, our experiences, we compiled them. Elena is a 58-year-old woman who is on dialysis, and she started dialysis about 6 months ago. She has diabetic neuropathy, lives in Pennsylvania, and has anxiety before she goes to dialysis treatments. She smokes marijuana, struggles with insomnia, and feels no sense of control over her treatment. She feels like she has no sense of control over her body while she is at those treatments. And she says, "I didn't tell my doctor, but I smoke to get through my dialysis." So why might patients like Elena use cannabis? To manage neuropathy, reduce anxiety, improve sleep, feel a sense of control over their treatment. These patients are discovering tools themselves that can help cope with their own symptoms and treatment without a doctor prescribing them for the most part. There's a high symptom burden in dialysis. About 50 to 80% of those patients experience chronic pain. About 52% of those patients report anxiety related to dialysis. And we're seeing an increase in marijuana use among dialysis patients. About 21% of dialysis patients reported marijuana use within the past 3 months. Up to 50% of dialysis patients reported use within their lifetime. And most of this use is not prescribed, thinking of prescribed being getting a medical marijuana card. And smoking is the most common method for using marijuana. So now, when we ask our patients why they use marijuana, what it helps with, they're anecdotally often reporting it's reducing anxiety, helping with pain. Now, what does the evidence suggest if we look to the literature? The evidence is suggesting that there might be some benefit for reducing neuropathic pain, possible benefits with CBD use and managing anxiety, small improvement in managing insomnia. This evidence is promising, but very limited. And the clinical reality for our patients is they're using these tools that are very loosely based on this evidence that there's no standardized dosing that the patients are following, right? And there's no monitoring of their symptoms. With smoking, it's very unpredictable. One strain can give different effects than another strain. Depending on how much they're smoking, they can get different effects, which can impact their symptoms differently. There's also trial and error use. Sometimes patients will say, oh, I used an edible and I had a really negative experience from that, which actually worsened my anxiety significantly. So whenever we're thinking about cannabis use in a medical setting, I would imagine that we think about what some of those risks look like. And I know that our team talked about that, and I'm not Kristen from the dialysis center, but I imagine this is what they talked about. So the dialysis team might be concerned about cognitive impairment, so some of that psychomotor impairment leading to potentially falls, cardiovascular effects from smoking marijuana, drug interactions with marijuana and CBD, respiratory risks, and just these unknown long-term effects that come up, and that's partially due to laws surrounding marijuana. But a balanced perspective when we zoom out and look at it is that cannabis isn't clearly linked to kidney injury with the literature. There's not strong literature directly linking it, but it's not risk-free. And the effects vary by use and by patient. So as a dialysis social worker, what does Kristen do? Or what do dialysis social workers do? Bridge the silence gap. So only about 34% of providers know that their patients are using marijuana. And a beautiful example is how Emily brought up how we got into this in the first place, was that at the Transplant Center, we started drug testing and, surprise, found out that many patients were using it. Patients are not disclosing use. And so these conversations about risk simply aren't happening. And part of that is because the conversations can be incredibly uncomfortable. I think most people have went into a doctor's office and been asked about alcohol use, and it can feel very stigmatizing. Those conversations about marijuana use can feel even more stigmatizing because of laws surrounding it. It's not entirely legal, it's a drug. And so reducing that stigma and normalizing that conversation as providers is incredibly important. And so one thing that I find helps is asking, what does it help with? And so giving them the opportunity to explain how they find it helpful, to understand, well, you find it helpful for anxiety. It sounds like this patient struggles with anxiety. Where else might we find room for intervention as well? Providing education. And now that we've opened this communication and made it feel safe, we can bridge the gap and bridge communication between the patient and their medical team. Remember, if patients don't feel safe telling us, we miss the chance to keep them safe.
Okay, so Kristen, the dialysis social worker, has worked with Elena. Elena's open with her about her cannabis use, and Elena wants to be referred for transplant. So that's where she shows up to our office. She presents for evaluation. She admits to using marijuana because we give her a safe environment to talk about it. And we also tell her that she's going to be drug tested. There are many times where a patient will say, no, I don't use cannabis. And then I say, hey, you're going to be drug tested. And they're like, oh, I do use cannabis. Which is, that transparency is really important because I do think it gives, people are scared. There's so many reasons why people may not want to disclose. And so telling them, hey, you're gonna be drug screened, let's talk about it now so that it doesn't come up later and we have to explain why we didn't talk about it. She tells us, hey, I'm really using this for anxiety and neuropathy. She lives in Pennsylvania. She does not have a medical marijuana card. So the question is, what should we do? This was the question we asked ourselves 2 years ago and didn't really have an answer. So now we're going to talk about all of the research and the things that we looked into to figure out what should we do. So the Organ Procurement Transplant Network and the Health Resources and Service Administration, they manage a lot of the transplant policy, and they don't tell us at all what to do. They actually give the onus to the transplant centers. Candidate selection criteria determined by individual transplant programs. Well, what do transplant centers do? A survey in 2018 was distributed to a bunch of transplant centers, and the results were wild. Everyone was doing different things. Some transplant centers were saying no use at all. Others were saying medical's fine. Others were saying you can do medical, recreational, we don't really care. Some were saying edible use only. Others, edible and inhalation are fine. Others, most, were just not specifying. Not only were the directions that the transplant center is giving so variable, but even whether or not they were screening for use, screening meaning asking about it or drug testing. 55% were screening, 20% were not screening, and then a lot of it was actually organ dependent. So within the same transplant center, liver might do one thing, kidney might do another thing, heart might do another thing. So what this survey data showed is that inconsistent policies really leaves us vulnerable for bias because there's no protocol. It's left to the discretion of the team members, and everyone seems to have opinions about marijuana. So it's history class time. We really thought it was important to go back and look at how we got here today. Why is marijuana such a controversial thing? So, marijuana, back in the 1800s, it was commonly being used in industry. For the hemp plant was being used to make paper and textiles, and it was being used medicinally for pain, muscle spasms, sleep, GI problems. It was so much being used for medicinal reasons that it was actually added to the Pharmacopoeia of the United States. So this was a book, the Pharmacopoeia was a book that doctors at the time would use to determine how to treat their patients. Things were going great. Until about 1910, there was an influx of immigrants from Mexico. And at the time, the powers that be did not like this, and they felt that they needed to create this anti-immigrant sentiment. So instead of directly oppressing a group of people, they just said, let's figure out what they're doing culturally and oppress that thing, such as marijuana use, so that we can then therefore oppress the group of people. So marijuana became this tool to just oppress people. So this is when the propaganda machine began. So in 1925, the headline of the New York Times said, quote, Mexicans crazed by marijuana runs amok with a butcher knife. This then led to the 1936 movie, you can see the movie ad, Reefer Madness. Reefer Madness was a film that depicted somebody using marijuana, becoming extremely violent, insane, as they said, sexually deviant, and went on to murder somebody. There was no evidence to support this, yet they created this propaganda that this is what marijuana does. So then everyone becomes scared of marijuana, and now you have a bunch of people who are motivated to shut it down. Let's shut marijuana down. In 1937, the Marijuana Tax Act was created. You will notice that the Marijuana Tax Act is spelled with an H. That was intentional. There's evidence to support that they intentionally spelled it with an H because that is the Spanish spelling of marijuana. So let's make this act scary, foreign, so that people are more likely to follow along with it. This act put a lot of federal restrictions on being able to get marijuana, grow marijuana, and there was lots of taxes added to doing that. Then, shortly thereafter, 1942, it's out of the Pharmacopoeia. Again, no evidence to support that. And then in 1952, it keeps going. Now we have mandatory sentences for people who are caught with marijuana using marijuana. And then the 1960s hit, and there is a counterculture movement against Vietnam. And those people protesting were smoking marijuana. So, how do we make those people stop talking? Let's just criminalize their behavior, put them in jail, and then they won't be a problem anymore. In addition to this, the powers that be saw a great opportunity to also criminalize behaviors of Black communities in inner cities by criminalizing marijuana, and then they had this opportunity to incarcerate them. In fact, for Black people to one white person compared to one white person would be arrested during this time, even though that the rates of marijuana use were all the same. So that takes us, we have the Controlled Substance Act of 1970, and this is where any research that was being done on marijuana was halted, because now marijuana was classified as Schedule 1, which meant that if a drug is classified as Schedule 1, it means that there is no medicinal purpose for it. It means that it can only ever be abused. And what this really did is it stopped the ability to research any potential benefits to marijuana or even the risks of marijuana. So the 1970s into 80s with the war on drugs, people are being incarcerated for it. And then the pendulum starts to swing in the 2000s. And people start to realize, wow, that movie Reefer Madness was very wrong, and we need to correct what we've done. And in 2014, Colorado was the first state to permit recreational marijuana use. So now we have this pendulum that has swung, but it's remained the states have the power as to how they treat marijuana, which makes this very complicated. I will say that recently, in April, the Department of Justice did make FDA-approved marijuana products and products that are regulated by states Schedule 1. This is very new information. We're still trying to figure out how all this is going to go, which is good because it will give us opportunity to research it more, but still unsure how this is going to go, what the territory is going to look like. So there was this quote, and there's a book out there that talks all about the history of marijuana and how dark it is. And the quote in the book says, marijuana as a drug and the laws that sought to control it played on some of America's worst tendencies around race, ethnicity, civil disobedience, and otherness. I think that's just a great quote that summarizes the history of marijuana. I am so sorry the Y is rogue on the slide. We've tried to be so cool and do a Canva. Did not work. We have to use PowerPoint, so it didn't transfer over very well. So one of the things that has been hard with the healthcare system is the healthcare system doesn't have a map for how to treat marijuana. The map that it's, I think, tried to follow is geography based off of laws. So for so long, we've looked to laws to determine how do we manage marijuana in healthcare. So has the transplant community. So you can see here, actually maybe you can't see here, it's very tiny at the bottom. This map shows which states it's legal, which states it's fully legal for recreational and medicinal, what states it's fully illegal, what states it's medicinally legal. So there is a whole lot of color on here, and everyone's doing really different things. This became a problem for us in Transplant because a lot of our patients live in New Jersey, in Maryland, in Virginia. All of these states, it's legal recreationally. So what do you do when somebody comes into your center in Pennsylvania, where it's medicinally legal, but they live 15 minutes over the bridge, and in a state where they can just walk into a dispensary and get marijuana? So then, is the answer, oh, well, if you live in a state where it's legal, you're good to use it. If you don't, you're not. Well, that sounds like a lot of geographical bias. In Pennsylvania, you do need a medical marijuana card, which Christina will go over on how that happens. There is some interesting legal protections that have started in some states, the states listed to the right, through court orders or through court proceedings and through various statutes. There are actually some protections in these states that prohibit a transplant center from declining a patient for transplant based solely on their medical marijuana use. There have to be other factors that the transplant team would have to argue in order for them to be deemed not a candidate. It can't just be off of their cannabis use. Okay, Christine's going to talk about Pennsylvania. Another A has gone rogue.
Yeah, once again, the Canva problem. So once again, going back to when we started this, we found that providers were giving inconsistent messaging, and even within the social work team, we were giving inconsistent messaging regarding if one patient needs a medical marijuana card and another one does not. So to get a medical marijuana card, it costs the patient $250 a year in Pennsylvania. And that includes the registration cost, you need a background check and a medical evaluation. Now, the medical evaluation is not happening with your doctor that you see. That's not the person who's prescribing medical marijuana. You go on to, there's a registry, and then you look at the providers who can prescribe medical marijuana, and then you'd pick a provider, make an appointment, and then that's how you would get prescribed the medical marijuana. The patients that I meet with will say, it's a 5-minute appointment, it's so fast, I just tell them I have anxiety and then I get a card. But it's costing them $250 to get this card. And there are assistance options. They are incredibly limited. So there's assistance options for people who qualify for Medicaid in a household of 1 in Pennsylvania. These are people who are making about or a little under $20,000 a year. And many of our patients right now are struggling to keep their electricity on and to feed themselves, so that extra $250 a year is huge. And what we kept finding is, what about the patients who aren't qualifying for the assistance but are still struggling financially? These are people with medical bills, and these are people with families who are struggling just to keep themselves afloat. So this cost is huge. Most of our patients, if not all, with kidney disease are going to qualify for a medical marijuana card. Think back to Elena. She has anxiety with her dialysis treatments. She's struggling with neuropathies. She has sleep challenges. And it also, for people who might have post-traumatic stress disorder, inflammatory bowel diseases, there are so many conditions that would qualify these patients to obtain a medical marijuana card that our patients are experiencing already. So, and it's important to note that this treatment is not approved or regulated by the FDA. Another thing with the medical marijuana card is that many of our patients would say to us, I don't want to get a medical marijuana card in Pennsylvania because then I have to relinquish my right to own a firearm. And so that would prevent people from wanting to move forward. And so one thing to keep in mind also, as Emily noted, is that with a medical marijuana card now, one thing that has changed is that would classify your use as a Schedule III drug instead of a Schedule I drug, which is a transition. So thinking about bias. So uncertainty in how we address marijuana use in transplantation itself lends itself to bias for or against use, which lends itself to inconsistent policies and procedure. So one provider might request a medical marijuana card for one patient and one might not. One patient might have to quit using marijuana to get listed, one might not. One patient might get closed for their marijuana use and one might not. And despite a lack of data substantiating the risk of marijuana use and transplant outcomes, marijuana users may be less likely to be transplanted than non-users. And substance abuse policies further compound the inequity that Black and other minority patients face and create a double jeopardy effect. And that effect is when you take a group that is already at a disadvantage for receiving a transplant, and then you further that disadvantage with that policy. So what does the evidence say? There are many factors pre-transplant that can impact a patient's candidacy. So many of these sit at the intersection of medical and psychosocial risks. So looking at the literature and within our own work group that we came together and worked on, we considered some of these medical risks. One of them being cannabinoid hyperemesis syndrome, and we have seen this come up. And part of that is these unexplained GI symptoms. The Philadelphia Inquirer recently came out with an article within the past week talking about scromiting, the scream vomiting that comes with cannabinoid hyperemesis. But really, these patients are going to the emergency department time after time due to the persistent cannabis use and not discontinuing. Pulmonary and cardiovascular concerns. And part of that, when we're thinking of mitigating the risk, so thinking of things like obstructive lung disease, how are they using marijuana? Are they smoking it? Are they using edibles? Could education be provided there? A big concern that's always brought up when we're talking about transplant and marijuana use is, what about postoperative infections? What about fungal infections in the lungs? And then we can't treat them. So one thing is, how can we actually provide education about what methods are you using? Are you smoking? Could we switch to edible tincture form? And research shows that improvements in sterilization of marijuana has led to a decrease in the fungus being on the flower. There's also, of course, post-transplant drug interactions that have been indicated with marijuana and the immunosuppressant that's prescribed, tacrolimus. So there's cannabinoid-related tacrolimus toxicity. And so one way that we can help mitigate that risk is getting pharmacy involved when we know that the patient is using cannabis. So with that, this can happen. It's really important to note that this can happen not only with marijuana when they're smoking it using edibles, but also with CBD. And so having pharmacy involved and getting them to be on board right at the beginning and giving patients that education can help in the long run. So thinking about psychosocial risk and transplant, we're considering psychiatric disorders, cannabis use disorder, cognitive impairment, but ultimately the biggest risk for poor outcomes with transplant is non-adherence. So a cannabis use disorder, when we're looking at the DSM-5, we're really looking for two of these criteria within the past 12 months to see if somebody is currently struggling with a cannabis use disorder. And at the core of that, we're looking for impaired control. So somebody who might have difficulty cutting down on their use. They've thought about cutting back, they want to cut back, but they find that when they try, they just simply can't do it. They have social impairment as a result of their use. We see this in clinics sometimes where the families will say, I want them to stop. Their use is concerning to us, and it causes tension in the home. Or maybe they're not able to fulfill their obligations in the home, but they don't stop. Risky use. And so earlier we're talking about the cannabinoid hyperemesis syndrome. So you're going to the emergency department time and time again, knowing that this is the problem, and you continue to use it. Some people, you might experience an increase in paranoia from your use, but you continue to use it. So seeing that risky use and that impairment as a result. And withdrawal, which looks different in marijuana. You can see cravings when you're not using, as well as irritability. 3 in 10 people who use cannabis have a cannabis use disorder, and that risk becomes greater if you've used before the age of 18.
Okay, so next we're going to talk about the psychosocial risk of the psychiatric risk that can accompany marijuana use. Now, this is a really tricky topic because there are two camps. The camp of, well, it helps my mental health, it helps my anxiety, it helps my depression. And then there's the camp of, no, it's increasing your anxiety, it's increasing your depression symptoms. The research is all over the place. The most recent research that we could find that seemed to aggregate all of the data that's out there, or a lot of the data that's out there, was actually recently done in 2026. And what this research said is that there's an associated risk for the following. I'm just going to point out, though, that associated is bolded. It's really important to acknowledge that it's an association. It's not necessarily, it isn't causation. And we'll talk about that a little bit with limitations around the study. There is an associated risk for increase of psychosis and schizophrenia symptoms. It also can exacerbate bipolar and mania, and there is some evidence that there's an associated risk of depression, and specifically suicidal ideation in patients with depression. And then there is also a risk of acute anxiety and panic right after use. But on the other hand, the research did indicate that there's some evidence that potentially it could help with anxiety. So it's really back and forth. Factors that they did say that influence the risk are the potency of the THC, the frequency of use, if use starts in adolescence or young adulthood, and if somebody has a history of a psychiatric disorder. The true conclusion of this research was that you need to do an individual assessment. This is very patient by patient based, and you really need to stratify the risk. Look at all factors that could be influencing the risk of the marijuana use. And really, in the context of transplant, the concern with this is that if somebody has a psychiatric disorder, has bipolar disorder, is experiencing psychosis, schizophrenia, and they're using marijuana and their symptoms are getting worse, maybe that's when their intervention is needed to talk about, hey, let's not use marijuana, see if the symptoms improve. The limitations around this study is really the accounting for compounding variables. It's really hard to account for compounding variables because the last limitation is that these aren't really random control trials. Again, back to marijuana being a Schedule I drug, we haven't been able to do random control trials, which is like the holy grail of research. So we can't, because they're not random control trials, we really cannot firmly say that there's causation here. We can't say that marijuana use is causing psychosis, just that there's this association that we need to look more deeply into. The other thing that's really a challenge is the inconsistent cannabis exposure measures across studies. There's no dosing really when people are using marijuana, so there's not really a way to compare, like you're comparing apples to oranges if you're looking at two people who are using different doses, different potencies of marijuana. So then we think about cognitive risk. So there is, again, some associated risk of impairment with attention, working memory, and processing speed. This is right after use, like while you're under the influence. There is also some associated risk for long-term or for chronic use of learning and executive functioning. Again, same with the psychiatric risk. The factors that really influence this is the dose, the frequency, and when you started use. So sorry you can't see that. So the limitations, again, really the same limitations, reverse causality challenge. We can't really definitively say that the marijuana is causing impairment to cognition, and there really is inconsistent cannabis exposure measures across study, and there are confounding variables that we can't really account for. So there is some research out there that has specifically looked at transplant outcomes and marijuana in cannabis use. There are two studies on the left side of the screen. There was one study that did note an association with acute rejection, but not graft loss or death. The rejection was able to be reversed. And an association of other psychosocial factors. So this is the marijuana use was associated with psychiatric disorders, with non-adherence. Again, the challenge with these studies is the causation challenge. Then there was another study that looked specifically at patients who were struggling with the cannabis use disorder. And they also indicated that the association was really with psychosocial problems post-transplant. and they did note some worse outcomes related to graft failure, but there was no way to prove that it was a causation. Non-adherent, so that we've talked a little bit about. So when it comes to transplant, that is probably one of our most concerning things when it comes to the psychosocial assessment. What factors can lead to non-adherence post-transplant, where a patient is not showing up for their appointments, they're not taking their medications? If patients don't take their medications post-transplant, as I'm sure you're all aware, they can face rejection, and that can happen pretty quickly, and there aren't symptoms, so there's no cues that they're getting of, wow, I should be taking my medication. So it really requires a lot of trust with the team. And it requires intervention to try and remove any challenges that might be leading to non-adherence pre-transplant. The one thing about non-adherence is medication non-adherence, like I said, increases the risk of graft loss. It is one of the strongest modifiable risk factors for rejection, though. So it's something that can be changed if we can work with patients and improve their adherence pre-transplant, or even if they're struggling post-transplant with non-adherence, we can work through those barriers with them. And estimates indicate that 20 to 25% of late rejection episodes are attributable to non-adherence. So it's happening a lot where patients are struggling with non-adherence post-transplant. So the multidisciplinary team, really, we looked at medical factors, we looked at psychosocial factors, and one interesting thing that happened is we worked with an incredible medical team, and they really said, hey, the biggest challenge here that we're worried about are the psychosocial challenges. Yes, there are some of these medical risks, but the bigger risk is psychosocial. So how about you guys, as the social work team, try and figure out what to do? So, poll question. I don't think we have Slido. Slido did not show up today. But this is a poll question for you guys. We're just curious what you guys think based off of what we discovered and learned in our multidisciplinary committee, what we should do with Elena. Should we tell her to stop cannabis use altogether? There's really nothing to do, let's just not talk about it? Should we tell her she must get a medical marijuana card? Or should we assess further for a cannabis use disorder? There really wasn't a right or wrong answer to this question. We were just kind of curious what people thought. And then, because we can't really answer the question, I'm just going to keep on cruising. So, what we determined to do as a team is mitigate risk. There is so much risk with transplant. Transplant is very heavy on how do we limit the risk so that we have good outcomes and that patients can go on and have a successful life post-transplant. And when we think of mitigating risk, what our team determined is we need to assess, we need to intervene when necessary, and we really need to educate. So what does assessing look like? Well, we want to assess for cannabis use disorder. One thing that I have noticed, that we've noticed, is that this pendulum has swung a little bit in the other direction, where now it seems like everyone's like, oh, marijuana's fine. Not everyone's saying that, but a lot of people are saying marijuana's fine. There's no risk to it. Let's just all use it and hang out. Well, that's not, somebody can absolutely have a dependency on cannabis. And so that's where having those conversations with patients of like, hey, I know you're using a lot. Did you know that somebody can be dependent on cannabis? Because that might not be a conversation that they're having with their peers. Or there may be actually a stigma of like, nobody can abuse marijuana. That's ridiculous. So what we're really trying to do is assess for a cannabis use disorder. So sorry you can't really see the chart on the right side, but what this actually is the CUT-IT-R. It's the Cannabis Use Disorder Identification Test. This is an evidence-based tool that is actually asking questions you administer with patients to ask them about their cannabis use. It's very reflective of the DSM-5 definition of cannabis use. We will say it's not the perfect evidence-based tool. The questions can get a little bit wonky with patients, but I think what it does more than anything is it gives us the pause to stop and really talk about it, to really go in depth of How often are you using? How many hours are you under the influence where you can't function? These are questions on it. I can go over some of the questions actually in detail. How often during the past 6 months did you fail to do what was normally? Did you find that it was hard to stop using cannabis once you started? How often during the past 6 months did you fail to do what was normally expected from you because of using cannabis? How often in the past 6 months have you devoted a great deal of time to getting, using, or recovering from cannabis? How often in the past 6 months have you had a problem with your memory or concentration after using cannabis? How often do you use cannabis in situations that could be physically hazardous, such as driving, operating machinery, or caring for children? And have you ever thought about cutting down or stopping use of cannabis? So these are the questions that we now, as the social work team, sit and ask patients. Other things that we're assessing for is how often they're using, frequency, and the amount. Other things that we're looking at as we're doing chart reviews, are they ending up in the emergency room with cannabinoid hyperemesis? It's pretty wild. I recently had a conversation with a patient. He was telling me how he's all these unexplained GI issues, and then they stopped. And I was like, okay, you have a past use of cannabis. And he's like, and I said, when did you stop? And he told me when he stopped, and I said, was that around the time that the GI issue stopped? And he's like, yeah. And I said, do you think there could be a connection? And he said, whoa, there could be a connection. So people just don't know about it. And it was, in fact, in his chart that there were concerns that he was going to the emergency room with cannabinoid hyperemesis. Other things, observed behaviors. We say this with a caveat because observed behaviors can be very subjective, so just being very careful with that, but it is something, are they somebody falling asleep in the room, and maybe they smell a lot like marijuana. Psychiatric disorders, again, just looking at, do they have schizophrenia? Do they have psychosis? Do they have bipolar disorder? Are their symptoms being exacerbated by their marijuana use? Getting collateral, calling the dialysis social worker, calling Kristen and saying, hey, Kristen, do you have concerns for their use? You see them way more than we do. Are they agreeable to switching to edible tincture form? Just prefacing this, saying, hey, how would you feel about switching? There have been times where patients have said, I absolutely will not switch. I'm not going to do that. And then that maybe makes us think more deeply, do they have a cannabis use disorder? If they're not willing to switch, are they dependent? And then concerns for non-adherence. Is there this big non-adherence, showing up in their life? And could the marijuana use be playing a role into that? And then probably one of the bigger things is multidisciplinary collaboration. Really talking to the medical providers, the nephrologists, do you have any medical concerns for their use? How do you feel about their use? Talking to the nurse coordinator about it, and then referring a patient to transplant psychiatry if there is a concern for psychiatric comorbidities, or there is concern for a use disorder. So we use the cut at R to help determine if we're going to make a referral or not, in addition to all this other information that we're looking at. So there have been times where we'll be concerned that somebody has been using cannabis for 30 years, and they use every day, and they're non-adherent. And these might be factors where we might say, okay, we need to send a referral to transplant psychiatry. The big thing here, too, is Christina talked about tacrolimus toxicity. The thing that happens post-transplant when tacrolimus toxicity occurs, which is rare, but it can happen, is the only way to resolve the issue is to have them stop using cannabis. If you have somebody who's dependent on cannabis, they're post-transplant, this interaction is happening with their medication, and we need them to stop using the cannabis to get their tacrolimus at baseline, but they're struggling with the dependency, saying, hey, stop your use is going to be a lot more difficult. And now they're struggling with this medication issue, and they're struggling to fight a dependency disorder. So that's where it might happen that we say a patient has to stop use. But this is all based off the individual assessment, looking at all risk factors. We also might, from the transplant psychiatrist and the social work collaboration, we may determine that a patient might need to go to support groups, go to an IOP, go to Marijuana Anonymous. The one thing that I've noticed about the IOPs, at least in where we are at, is I actually had a patient who had a DUI for cannabis use, and he was, by probation, told he had to go to an IOP, and he went to the IOP, and the IOP said, oh, like, that you don't have a problem. So I do think that there are some, and a lot of that I think comes from a good place of harm reduction, and but it definitely can get complicated if our team is saying, hey, this person does have a use disorder, we need to get them connected to a program like an IOP. We have to find an IOP that would take them, which is where our role really comes in as well. And then through all of this, we'll tell a patient, hey, you may need to have, or you do need to have negative drug screens so that we know you're not dependent. And then if a patient doesn't have a cannabis use, or we're not concerned for a cannabis use disorder, that's where we're really educating. We're educating patients on the risk, the inhaling risk of infection in their lungs, the tacrolimus toxicity risk of medications, and the risk of a cannabis use disorder. In addition to this, we're also talking about contamination. Hey, make sure you're getting your marijuana from a safe place. One thing that we do not do is we, as a program, do not require a medical marijuana card. The reason for that is because of so many things that we reviewed, that essentially what we would be doing is we would be saying those who can afford a medical marijuana card, you can continue using. Those who cannot afford a medical marijuana card, sorry, you can't. That right there is creating a disparity. In addition to that, like we said, New Jersey, Maryland, all these places around us, you can go into a dispensary. So we tell patients contamination is a real concern. We're giving you your own autonomy to make sure that you get it from a safe place, however that is. And then transparency, just emphasizing, talk to us about it. Talk to us about your cannabis use. Don't hide it from us. It's really important that we know so the medical team can make appropriate decisions if something does come up. So Elena, back to her. She gets transplanted. And she decides, post-transplant, that she's going to continue using marijuana because she does have some residual anxiety, and it's been helping her, but she's agreeable to switching to edible tincture form. Our medical team will continue to monitor her tacrolimus levels if there would ever be concern that there's an interference with the cannabis and the tacrolimus. Then they would send a referral to us or to transplant psychiatry and just ask us to help address it. I will say, in my 3 years and Christina's 3 years, that's never happened. But we just really want to mitigate that risk. So takeaways. Takeaways from this presentation and project is really evidence over status quo. I think we can get in these cycles where we just keep doing what we're doing because we've always been doing it. And we don't take a minute to pause and look at why we do it and determine if there's evidence that maybe we should switch things up. Multidisciplinary collaboration, that was a huge, the reason we're here today is because of the multidisciplinary collaboration that we had the honor to do with our nephrologists and our nurse coordinators and psychiatrists, and that we continue to do with all of our patients. And I imagine there's a lot of social workers in the room. I definitely think it's important, we sometimes have to earn our seat at the table, but part of that is just saying hey, I'm here, can you listen to me? And that can be scary, and it was scary for times with us on the team. And having those specific transplant nephrologists that were allies of ours who really saw our worth, I think was really what helped us be successful in this multidisciplinary work group. And then using assessment tools when we can, trying to come up with more objective assessment tools that we can pull on. And I just want to leave everybody with this reminder of the 4 principles of medical ethics. The 4 principles of medical ethics are respect for autonomy, beneficence, non-maleficence, and social justice. And I think the principle of medical ethics come up a lot in this protocol, in the sense that we have to respect the autonomy of our patients. They have the right to choose what they, within reason, they have the right to choose what they want to do. And what our job as medical providers or as social workers is to really identify, are we doing harm? So non-maleficence, we need to not do harm. So what is the risk versus benefit? And then beneficence, acting in the best interest of the patient. And if the patient is telling us that this is helping them with various symptoms, we want to act in their best interest. And then social justice, which is huge in transplant. We need to be removing unjust barriers so there's greater fairness and equity in healthcare and in transplant altogether. So, any questions or comments? Seriously, we want to hear if somebody totally agrees with this policy. We really want to hear it because I think it's important that even though we have this protocol in place, that we're continuing to challenge it and figuring out how to make it better. So if there are any transplant social workers in here, we'd love to hear your policy, what you guys do, or if you have any questions for us. Thanks.
That came in on the app, so maybe we can start with those.
Cool.
So we have one question that asks, how do we think about patient cannabis use to treat symptoms versus treating withdrawal symptoms now that we learned more about physical withdrawal from cannabis?
Do you want to take that? No. Can you repeat it? Sure. Sorry.
Kind of a two-tiered approach here. So how do we think about patient cannabis use to treat symptoms versus treating withdrawal symptoms now that we learned more about physical withdrawal from cannabis?
It's hard to answer that as a social worker because I can't really speak to treating medical symptoms. And so I think that for us, I can speak more to what our role would look like when it's identified, which would be that we would identify what the symptoms would look like, which would really be more psychological, more than physical withdrawal would be what we would see. We would be seeing more irritability. And so that would look more like finding ways to cope. So figuring out if they need to be in meeting with our psychiatrists, our transplant psychiatrists, or seeking out different resources within the community to try to get some coping strategies to manage some of the irritability and cravings that they're having. So thinking of urge surfing and things like that.
Have you, just kind of to piggyback on that, have you experienced yet on your team your doctors coming to you saying we're concerned about this patient withdrawing from cannabis and addressing that? No?
No.
Yeah, okay. Then more of a comment, marijuana from a dispensary is a lot more expensive.
Yes.
So any thoughts on that? Yeah.
Yes, it's a lot more expensive, and what we will actually find is that a patient will have a medical marijuana card, but they're not getting it from a dispensary, they're getting it from their next door neighbor. And we can't control that. We can't. And so that's where the education is important. Ensuring, asking them, do you understand the risk? And emphasizing that there's more risk in getting it not from a dispensary.
I'm Laura Tuschel. I'm a transplant social worker. I'm the one that's talked about the price, which is why a lot of people don't necessarily want to switch to the edibles because of cost, or at least in my patient population. I would say we have struggled with it. We've chosen to not be, I'm going to use the word, too concerned about marijuana for a long time, because if it was a deal breaker, there's not a lot of patients who'd get transplanted. And that was even before Illinois made recreational legal. Interestingly, some of our state-based Medicaid managed care plans still require negative tox screens, even though it's legal in Illinois. So one of the things that our pharmacists are very adamant about the drug interactions with the tacrolimus. I don't think we've ever seen anybody that it's actually impacted their transplant outcomes. I think we would have a whole lot more rejection if it was really interacting, but that's my social worker take on it. I'm sure the the drug curves, the area under the curve, I'm sure it all is like in a lab, it all works out, but in the real world, I think we'd have a lot more problems. We have had a couple of people, and they tend to be diabetics, long-term type 1 since they're young, with a lot of GI issues baseline, who are treating, self-managing with marijuana use, who then end up with the hyperemesis. And I do think for some of them, it is a combination. When they do try to stop, they are struggling with both what's hard with that question I think somebody posed before is like, how much are the baseline symptoms when they stop or decrease their marijuana use? How much are the baseline symptoms that they've been self-medicating for? How much is withdrawal? And how much is anxiety related to? And so one of our challenges for some of these folks is like, how do you actually get treatment? Because like you said, so many places say, oh, it's just marijuana, including drug treatment programs. It's actually very hard. And so we struggle with like, how do we help them when they are ready to? And so that's my commentary. The question I have is, have you looked at or considered the medication-assisted drug treatment, if that has any role in marijuana cessation?
I can tell you that our psychiatrists have never pulled that as an option. Is there a specific medication that you're thinking of?
No, one of our nephrologists mentioned, is that something? And
yeah.
I wasn't sure in your team meetings if that came up as a
No,
option.
it's never come up. The big thing that we actually have just tapped into is the resource of Marijuana Anonymous. There's a specific platform for patients to find a meeting that's all about marijuana use, because I do think the experience of somebody trying to recover from a marijuana use disorder is very different from somebody who is struggling with a different substance use disorder. There are a bunch we did put it on the slideshow, the link, and you can find meetings all over the country online. They have the meeting names are really fun. They really play off the marijuana thing.
One thing I've found kind of interesting is at times you'll have some providers that will be very comfortable prescribing Marinol, and then there's this element then of still feeling that stigma and concerned about cannabis. So I don't know if anybody else has experienced that as well.
I think that to comment on that, I think the one challenge is the fact that marijuana is unique in the sense that it's used as a treatment, but there's no prescribing. Like, there's no doctor overseeing the prescription of marijuana. It's like you're the person that just sits in the marijuana dispensary and knows a lot about weed is basically the one that's giving you advice on what to take. So I don't know if it's too just that they feel like they don't have control over the prescription, the dosing, like they might with the FDA-approved like marijuana-based products.
That's a great point. And then it goes back to the big concern here of with it being still scheduled as a Schedule I drug, you can't fully vet and research to compare the two equitably.
Right.
There was a comment, a goal would be to work toward a consistent determination among all transplant centers. Absolutely. Yeah.
Totally.
Big one.
Yeah, sorry, just a quick question,
Yeah.
and it could be odd too. When you're doing your assessment, so you do the screening tool and you're documenting all those risks and stuff, are you entering marijuana into the medication reconciliation? Okay, that was my debate.
No,
Okay.
we're not. It's actually recently been brought up by pharmacy. Pharmacy has actually wanted it to be on their like medication list. Is that the specific? Yeah. Yeah, just because then they can keep more closely eyes onto it, because truly it's the best place that you're going to know if a patient is using marijuana or not is in our note, which I'm not sure if they're looking super closely at that. So that has been something that we've been discussing. Yeah.
It's just an interesting thing because like you can't confirm the dosage.
Right. I think that, right. I think that there might be like just a general like medical marijuana option that you can just put on their med list. But then it gets tricky because it's like, if it's not medical, we don't require medical marijuana cards. So then what do you put down on it? Yeah, good question though.
And then we had a few other questions come in. How should transplant programs consider evidence linking cannabis to risk of death during cardiac event and risk of vehicle fatality in setting of intoxication?
So I think I understand the question. The big thing here that we're talking about is if somebody is acutely intoxicated with marijuana and they're doing dangerous things, then I would have concern for a cannabis use disorder. So that is how at least our transplant center would look at it. So that patient who did get a DUI, the concern there was, and it was recent, the concern there was, okay, you're using marijuana and then you're doing physically hazardous things. And as we know, the acute intoxication in marijuana does lead to cognitive impairment while you're under the influence. The question, the more medical question, I really don't know if that's being documented anywhere. Yeah, I don't know. The more medical, the medical. And that's, I think that some of these questions too are like the questions to ask the whole healthcare system, not just transplant in general. So I think we just need to keep asking these questions and really to asking our medical providers to look deeply into this. And then hopefully we also get more research moving forward.
And what about patients who use cannabis to treat symptoms for sleep, mental health disorders like anxiety, and then have not sought more standard treatment? How would you say we should address that piece?
It is really challenging when you find patients that find the tools for themselves to self-medicate and they're using cannabis. And so thinking of things like anxiety and sleep specifically, I'm thinking back to a specific case where the patient this was in the beginning before we had any policy. The patient was told they had panic attacks and they would smoke marijuana to help manage their panic disorder. And then they were told they had to stop, so then they got prescribed Xanax instead. And so sometimes it's thinking about how are we mitigating risk and what's the better choice and how can we give them other tools. So I always think the way that you're asking them and assessing is incredibly important. And the Cut It R is incredibly flawed because it really is just looking at the DSM and how we're putting people in boxes to get numbers. It's good. There could be something better. This was just the beginning. Now, when we're talking to the patients in a way that's destigmatizing, asking them what they use it for and how it helps them to get an idea of what's happening for them. And then I ask them oftentimes to explain, like, how do you experience anxiety? What does that look like for you? How does it feel in your body? And then when we can get a much deeper picture of what it looks like, then we can get an idea of what direction can we point them in to help them, to give them stronger tools, rather than only the marijuana, which then becomes sort of their own Xanax in a sense, just a little bit maybe safer in some ways.
There also have been times where I have seen our psychiatry team and worked with them on cases where a patient might be teetering on we're unsure if they have a cannabis use disorder. Let's try them on a different medication for sleep that like the psychiatrist can prescribe. Ask that patient to stop the cannabis use for a period of time to get a feel for, is there a better option? This patient specifically, though, also had a lot of psychiatric comorbidities that we were also trying to navigate through. So there was this intersection between the marijuana use, psychiatric disorders, and then also, just the intersection between psychiatric disorders and sleep.
Is it a regular occurrence when you're tox screening your patients to have other substances pop up outside of cannabis?
It happens, for sure. I would say we'll see cocaine pop up sometimes, prescription meds that aren't prescribed. We're actually currently working with the same multidisciplinary group to create a more in-depth protocol for all substances, because at this point we started with marijuana because there was an immediate need for it, and now we're looking at how are we going to treat other substances, because right now it is kind of a case-by-case basis dependent on the medical team and the social worker and their judgment.
Makes sense. You mentioned bringing nephrology in to address patient cannabis use, but as we know, providers are human and have bias as well. Could you share any tips for navigating when a patient and provider are at odds?
Well, now we have a protocol. So now we say, go read the protocol. Respectfully. So that's why we did this, truthfully, because there is everyone has their opinions, and I think that we actually have been really successful in the nephrologist mostly comes to us and says, hey, I just met with a patient, they're using cannabis, can you check it out? And then they just will, in selection, talk about their use, talk about the cut at R score, say if we have any other additional concerns, and if a patient needs to be referred to transplant psychiatry.
Yeah. I wrote that one, and I live in Indiana.
Yeah.
So, like, in my mind, I have a provider and a patient, and they are at odds, and so I'm just trying to figure out, like, the best way to have
Oh, okay.
respectfully for both parties.
Yeah.
I want to advocate for the patient.
I'm wondering if you just ask the nephrologist, like, what are you afraid of?
Mm-hmm.
Are you afraid that they're going to get an infection? Like what? And then see what they have to say. And just really, I'm also curious, has this nephrologist ever allowed it for other patients?
Not to my knowledge. And
Okay.
it's a dialysis center.
Oh, dialysis. Okay. Interesting. Yeah, I'm really curious why they don't want them to.
I imagine it's personal bias.
Yeah, sounds like it. Yeah. And I think that's where just like asking the questions, like, what are you afraid of? And then maybe they're not going to, they just need to identify that there's not anything to be afraid of. So then what is the reason you're saying that you have to do this? Yeah. No, you're good.
But I think in my experience with this topic, some of it is stemming from organ allocation itself. I'm biased here. I feel like social workers come from more of an equitable, justice-focused mindset versus some of my providers, including my post team, they're very judgmental on marijuana use, very paternalistic, and you got this organ and you're not deserving of it because of your marijuana use. And I've seen it. And that's why I asked you to document it, because I'm almost to the point where I'm like, I'm not documenting in the medication list that they use marijuana, because I'm concerned maybe that might be a bias in when an offer comes up.
What state are you in? You're in our state. Yeah, you're in Pennsylvania. Oh man. That's right. I knew that. Man, oh man. Even if they have medical marijuana?
Well, so we recently, I was pushed that we
Nice.
don't need should not require the card for the reasons that you gave.
Yeah.
And it got big pushback, and one of it was, if they're getting this organ, they should do more in deserving this.
Yeah. It's interesting because, Christine and I will talk about this, and we said it like, really, I mean, truly, this is just being pretty frank. Like, we don't tell our patients post-transplant, don't ride a motorcycle, don't eat Twinkies, don't, we're not, there's risk in all these things. There's risk in medication that's prescribed. And so I think it is, I think, a lot of education. And that's why when I started reading about the history of marijuana use, I really realized that where we are today is because of bias and oppression. And are we really going to continue that? Like that? So maybe they need to go to history class. In the back.
So I come from the clinical social worker with an addiction background, became dialysis. And
Oh, very interesting.
First of all, I really appreciate you today because the two talks that are being put on by the networks on cannabis use and transplant have all been very sensationalist type lens toxicity. But then I was curious about this after my first one. And so I've encountered this as well with pharmacists, this alarmism. There's this one case study that has to be cited with another phase 1 pharmacokinetic study in the works. But basically, you have to consume about 200 to 250 edibles a day to reach the same level of CBD that was found in the toxicity case study, right? It's ridiculous. And so, to your point about what is the objection, I hear often the objection is a concern for transplant toxicity should be given transplant, but they don't really read the studies. They don't really kind of question what's going on, which speaks to the greater thing that I know we've been tiptoeing, but it's in white supremacy and racism that has drug use signifies other groups, including the myth of the black men with human supreme powers because they're on crack cocaine. Karl Marx writes a lot about this, and he's wonderful because he's a Columbia neuroscience breakdown, all these studies that are used to justify how we demonize people of color and drug use. But I do find this pretty interesting, and I do appreciate that you didn't spend 30 minutes talking about how don't do it because it's going to poison you with track lines, because that's really not the case. Unless you're consuming about 100 to 250 edibles a day.
Thank you for that. I really appreciate that feedback. And to your point, the study that everyone quotes is with CBD. So it just, yeah. It feels like we're looking for something to be the problem.
This just kind of brought back a memory. I had a patient I was working with who I was doing a transplant eval, and he was very involved in the cannabis rights movement in California. And I would say, on average, California is a pretty cannabis tolerant state. And I used the word marijuana during the eval, and he said, you need to cut that out. It has systemic racism roots, and cannabis, it's a plant. We should be using the scientific name and move to be taking away that bias simply associated by calling it marijuana. And I just find it an interesting point that still a lot of programs in medical settings are using the word marijuana, and we haven't quite gotten to that evolution of using it more as a medical term of cannabis.
Thank you so much for saying that, because the whole presentation I was like, say cannabis, say cannabis, say cannabis, because it's so ingrained in our minds to say marijuana. I mean, it's called a medical marijuana card too. And it is, like, looking back at the Tax Act, you see how it is rooted in this oppression and white supremacy.
Let's see. I think that wraps up the questions we had online. Is there anything else that anybody would like to share, thoughts or questions? Well, thank you so much to Emily and Christina for being here, and Kristen, we're sorry that you weren't able to make it, but deeply appreciate her contributions as well.
Thank you, guys.
Thank you.